Hi everybody. Today I want to start with acute pancreatitis and its treatment and drug discovery. Acute pancreatitis is one of the important gastrointestinal disease, and it is acute inflammatory disease. And this disease has several clinical symptoms. Usually, the patient has upper abdominal pain with nausea and vomit. And sometimes the patient has a fever and abdominal distension. When the patient comes to the clinic or hospital, usually it has a high pain and more compliance. And the best way which physician can use for diagnosis is the check the amount of lipase or amylase. Usually in the acute pancreatitis, both of them is high. The pain can be 3 to 5 times or more. And we can use ultrasound from abdominal, and or we can use CT or computed tomography. If from these clinical symptom and diagnosis, two of them is true, usually the patient has the acute pancreatitis, mainly if has a very high amount of the lipase and amylase. And also we can use abdominal ultrasound also. But sometimes, because of the early phase, the diagnosis with these two is hard. But mainly with ultrasound we can find inflammation in the pancreas, but mainly for the diagnosis, very high amount of lipase and clinical symptom. What is the cause of acute pancreatitis? As you see here, we can show the reason of the acute pancreatitis. We can say idiopathic, gallstone, ethanol, trauma, steroids and mumps, and autoimmune, scorpion sting, hyperlipidemia or hypercalcemia, and ERCP or endoscopic retrograde cholangiopancreatography, and drugs. Okay, but what is the highest reason from which one is very important? Usually the one of the important reason of the acute pancreatitis is the gallstone, because gallstone can block the pancreatic and biliary duct, and in this case it can cause acute pancreatitis, and also can be possible with the ethanol and the hyperlipidemia. If we have both of them, it also can cause acute pancreatitis. And others also rarely can happen, but I mentioned here. About severity of acute pancreatitis, usually we can classify in the several type of the classification, and depend the time is very important, and about we can classify also severity. Mainly pancreas, in the acute pancreatitis we can classify in two phases. In the first week is the early phase, and after first week is the late phase. But for the severity, we can say we have a mild, no organ failure. Usually amylase and lipase is high, but no damage of the organ, as a mild inflammation of the pancreas we can see. In the moderate, organ failure less than 48 hours can happen, and in the severe, organ failure can be longer than 84 hours. We can classify it mainly in the two types of the result in the acute pancreatitis. Okay? Less than 4 weeks or more than 4 weeks. Usually in the acute peripancreatic collection, we can see usually happen edematous or edema happen in the acute pancreatitis. And in the edema, we can classify in two groups. Less than 4 weeks, we can see acute pancreatic collection, and after 4 weeks, we can see zoidocyst. Okay, both of them is belong to the edematous. But in the necrotizing, we can classify it before 4 weeks. We have acute necrotic collection, and after 4 weeks we have a valid of the necrosis, which it has surrounded by the membrane, and it is usually full of the liquid also in this form. Okay, as you see here in this shape in the CT, we can see also again we have edematous and interstitial edematous pancreatitis. We can classify in two phase, less than 4 weeks and more than 4 weeks. Less than 4 weeks is acute peripancreatic fluid collection. We can see the collection of fluid around the pancreas, and it is a homogeneous fluid adjacent to the pancreas without recognizing wall, no wall. We can see some parts in some liquid falls here and without any symptom. But after 4 weeks, usually encapsulation happen, encapsulated with the well wall, usually extrapancreatic fluid collection with minimal solid, and we can't see necrosis. But in the necrotizing pancreatitis, in the less than 4 weeks, we can see acute necrotic collection, usually intra and extrapancreatic necrosis collection without a well-defined wall. We can see in the several parts of the pancreas inflammation and necrosis, but after 4 weeks it is a wall of necrosis, usually intra and extrapancreatic necrosis collection with a well-defined wall. It's walled. Okay, and severe acute pancreatitis or SAP, usually we can see pancreatic necrosis, or it can cause systematic inflammatory response syndrome, SIRS, and sometimes also severe multiple organ failure can happen because of the systematic inflammation, and also infection can be happen, and the compliance pancreatic abscess, as I mentioned, pancreatic zoidocyst, shock, organ failure can be happen, or secondary infection, as I mentioned, in the abdominal cavity, respiratory tract, and the urinary tract. In this case, we have a very high complication in the patient, and it's very important for the treatment. Usually, mortality in this case is very, very high. This page about physiology of acute pancreatitis is very important. How acute pancreatitis start and what is the cascade behind it, and what is the process and the mechanical cascade in the cells can be helps for this disease. As you see here, one of the reasons for the acute pancreatitis it is a gallstone, or it can be because of the tumor also. It can cause duct obstruction, as I mentioned, usually by the gallstone, chronic alcoholism. Okay? And what's happened here? It can cause interstitial edema because, as you see, fluid collection in the pancreas and the activation of the pancreatic enzyme can be happen. Impaired blood flow because of inflammation, but then problem is in the blood flow and the ischemia start. Okay? And usually the first reason is this one. Mainly, as I'm saying, the first reason of the acute pancreatitis because of the duct obstruction. But the other second reason may be acinar cell injury because of the alcohol or drug, virus, ischemia, or trauma. All of them can cause injury of the acinar cell. Acinar cell is full of the enzyme, pre-enzyme, inactivated form or zymogen. This enzyme can be activated and it can be destroyed the other acinar cell and pancreas also. Release the intracellular proenzyme and lysosomal hydrolysis. It can cause activation of enzyme, as I mentioned, and again increase the acinar cell injury. The third reason, defective intracellular transport, usually because of the metabolic injury, alcohol or duct obstruction can also be happen. And delivery of the proenzyme to the lysosomal compartment, and in this case, intracellular activation of enzyme can be digested of the acinar cell and can cause acinar cell injury. And when acinar cell injury, we have a storm of the enzyme because of the activation of the enzyme. Okay, and when the enzyme is activated, intracellular inflammation starts as edema, proteolysis because of enzyme protease enzyme, and fat necrosis because of the lipase and phospholipase, and hemorrhage because of the elastase can be happen. Okay, this enzyme can cause acute pancreatitis. But what is the pathophysiological background? After acinar cell injury, NF-kappa B can be activated. It is the reason of the inflammatory cascade and cytokines. Okay, it can cause immune system is activation, and it can be activation of the neutrophil and the macrophage and T cell. And this can be attack for the pancreas because of the inflammation, can be increased acute pancreatitis. Also, pro-inflammatory mediator also increase. Nitric oxide, tumor necrosis factor, interleukin 1, 2, 6. Reactive oxygen radical also activated, increasing. Hyaluronic acid metabolites, which can cause COX and LOX can be activated, and it can cause increase the inflammation and can cause acute pancreatitis. Anti-inflammatory mediator like interleukin 10 and interleukin 1 try to decrease the inflammation, but usually it does not happen because it's down regulation. It is very rarely can be happen because of the high activation of the enzyme in the pancreas. Usually, as I mentioned, the pathophysiological background, we can say pathology of acute pancreatitis, one of the important things we can see in the pathophysiology. The first one is stromal edema, vascular accumulation because increase the permeability in the vessel in the pancreas, Acinar necrosis because of the enzyme effect and destroy of the cell by the enzyme, and also inflammatory infiltration of macrophage and neutrophil because of the attack for here. And as you see here, it is very important, and we have to know about it. And molecular and cellular mechanism of acute pancreatitis. The first one is the premature trypsinogen activation. Usually can happen with the various stimuli, alcohol, pancreatic duct obstruction, and trauma, and because of oral release of lysosomal cathepsin B. As you see here in this shape, also you can see from the article, alcohol or trauma can cause the activation of lysosome. In this case, cathepsin B activation happen, and it can cause activation of the RIP3 and the RIP1, which I will teach in the necrosis cascade, and it can cause necrosis. It's one of the important molecular and cellular mechanism of acute pancreatitis. The second mechanism which is important in the molecular and cellular mechanism of acute pancreatitis is calcium, because calcium overloading and the mitochondrial dysfunction can be happen because overload of calcium can induce in the mediating mitochondrial dysfunction and injury of the pancreatic Acinar cell. As you see in the first shape and the second, if we have here mitochondrial depolarization, when the calcium is high, TRPV4 channel can be open and is responsible for sustaining of calcium concentration evaluation in the acute pancreatitis. As you see here, it is calcium increasing, and this channel has a high role for the acute pancreatitis. Also MPTP, mitochondrial permeability transition pore. It is the inner membrane of the mitochondria, can lead the mitochondria swelling, and cell death can be happen because of the mitochondria dysfunction. Molecular and cellular mechanism number 2, calcium overloading and mitochondrial dysfunction. We can say again, I can show in this cascade again, as you see here, as you see, when the amount of the calcium increasing can affect for the ductal cell with the help of MPTP, and also one of the reason here, calcium permeable in the ion channel, piezo-1 channel stimulation can be occur, and it can cause increasing of the calcium. It's very important. Sorry, because of the presentation, this part overlapping the text, and piezo-1, it can be open and the calcium go inside the cell. When the calcium increase inside the cell, in this case, calcium can affect for the dysfunction of the mitochondria. And the reason, as you see here, we can say with alcohol and citric and bile acid, for example, in the animal experiment with the mice, we they usually use cerulane, CCK analogs in the high dose, and it can cause acute pancreatitis. Okay, this one can cause the activation of ORI1 and channel, which can open and increase the calcium, and also affecting the endoplasmic reticulum and increase the calcium release with the hypothyroid mechanism, like affecting the hypothyroid receptor. Calcium overload and the mitochondrial dysfunction. We can continue with this topic. Calcium ion concentration can activate molecular nuclear factor NF-kappa B signal pathway. In this case, secondary cascade can be start, and it is one of the reasons for the inflammatory response. And the N6-1 channel, sodium calcium exchanger 1 ion promote was bound with an NF-kappa B, and it can cause overload in acute pancreatitis, and the development of the acute pancreatitis can be happen because of increased amount of calcium. And the last one, micro circulation distribution, can be I can mention about this because, and in this case, multiplying secretion of inflammatory cytokine, in this case cytokine increasing, and the result in the pancreatic micro circulation disorder. Usually cell damage happen when the in the vascular endothelial cell exposed to the nitric oxide. Nitric oxide will be increased because, as you see, nitric oxide can be from L-arginine. We can have a nitric oxide synthesis can be happen L-citrulline and plus nitric oxide. Nitric oxide can affect in the CGMP cascade, and it can cause muscular relaxation can be happen, and also this nitric oxide can affect in the excitation of the peptide BK or platelet activation factor PAF, and promote development of acute pancreatitis from the edema to the necrosis, because it can cause coagulation can be happen, and in this case unfortunately from edema convert to the necrosis. The early microcirculation disorder of the pancreas can directly or indirectly damage of the pancreas, resulting in ischemia injury as well as inflammatory reaction. The last one here, we can speak about inflammation in acute pancreatitis. Usually activation of NF-kappa B in early phase and central event in the production of the inflammation in acute pancreatitis. In NF-kappa B is inactivated in the cytoplasm by formation of complex with inhibitory protein IKB, and prevents the translocation of the NF-kappa B into nucleus. Until here is a normal situation. As you see here, we can see is here in a mechanism start from here. As you see here in the mechanism, when start inflammation NF-kappa B, it is inactive and it cannot go to the nucleus and start transcription. And as I mentioned here, NF-kappa B inhibit by the IKB, okay, and prevent translocation to the nucleus. As you see here, it is the IKB, and they are inhibit the NF-kappa B, and there is no transcription and mRNA synthesis in the healthy pancreas. It is very important. Okay. In the acute pancreatitis, tumor necrosis alpha, interleukin 1, could bind to the receptor and activated I-kappa B kinase. It's very important. Then it can dissolve or the inhibitor protein, and NF-kappa B can be activated, and the formation of the P50-50-65 dimer, okay, into the nucleus can go to the nucleus and start, because target gene of the P50, it can cause activation of the transcription and the gene expression, and in this case it promotes apoptosis factor BAX and the tumor necrosis alpha in this case, and it can cause cell apoptosis or necroapoptosis. As you see here, if when activation of this system happen and it make a complex P50 and P50-65, and it can go and here transcription happen. As you see here, for the activation we have the great IKB, and the activation can cause increase the transcription translation of the inflammatory cascade and apoptosis. The other situation, it is the C1q tumor necrosis factor related protein 3, CTRP3, exert protective effect in the acute pancreatitis by via suppressing silent inflammatory regulatory 1. It's very important we know about that one, because it also has a positive effect in the prevention of the acute pancreatitis and decrease inflammation. All pathway of the NF-kappa B activation could be blocked by treatment with a variety of the antioxidant. Usually we can see in the articles in acetyl L-cysteine, NAC, or glutathione, and thyrodoxine and organosulfur compound can help for the blocking of the NF-kappa B. And the role of the pro-inflammatory cytokines, usually pro-inflammatory cytokines and tumor necrosis factor, interleukin 1B, interleukin 6, and the interleukin 8 directly accelerate the cause and course of the inflammatory process and inflammation. Okay, we can see in this article they can interact with the peripheral blood mononuclear cell or PBMC, leading to Acinar cell apoptosis. And also tumor necrosis factor can activate it and damage the endothelial cell to secrete vascular adhesion factor PECAM1 and intracellular adhesion factor ICAM1 and selectin also. It can also affect in the increasing inflammation. For example, if you see here, after inflammation start and trypsin activation start and the NF-kappa B increase, in this case inflammatory cytokines and also tumor necrosis factor, interleukin 1B, 1 beta 6, 8, CXCL1, MCP1, ICM1, but as I mentioned, increasing in this case affecting the permeability of the vessels and vascular permeability increasing, and in this case infiltration of the inflammatory cell and white blood cell, and increase the attack for the pancreas, and the acinar necrosis start, and abscess and edema can be happen. Interleukin 15 treatment protect mice from the cerulean-induced chronic pancreatitis pathogens by regulating fibrosis and inflammation. In this case, we can see in the article, in the practice and in the experiment, interleukin-15 treatment helps for the prevention of the acute pancreatitis. And interleukin-6 facilitate neutrophil infiltration and provide novel cellular signal pathway. And interleukin-6 promote TMEM16A expression via activation interleukin-6A and STAT3 signals, which will be studied. We will study later in the pathogenesis of the acute inflammation. And also, inflammation can be happening with the infiltration of the inflammatory cells. Acute pancreatitis is characterized by the high inflammatory cell infiltration in the pancreas. Usually we can see neutrophils, which are the key participant in the acute pancreatitis and cause of infiltration. They could release MPO, myeloperoxidase, and the ROS into the interstitial to exert toxicity, and in this case also inflammation increase. See ABL kinase inhibitors like GZD824 in L-arginine-induced pancreatitis. We see in the practice, in the experiment, decreased amylase level and decreased pro-inflammatory cytokine level, and also affecting the neutrophil infiltration and also Acinar cell necrosis. The other mechanism of acute pancreatitis, which I can speak about, is oxidative stress. ROS can induce migration of the leukocyte into inflammatory cytokine. It can increase inflammation and the chemokine secretion. And oxidative species, we can like hydrogen peroxide, are second messenger in the inflammation. It also can be increased. It can activate the inflammatory cascade. Also, ROS induce DNA injury because it can react with the DNA and could be reflected by the increased level of the lipid peroxidation. Also can be effect for the lipid peroxidation and also myeloperoxidase activity and the protein carbon is in the patient with SAP also increasing. Also, there is a relation between the ROS and the calcium signaling. Okay, as I mentioned to you, increase the calcium inside the cell can cause acute pancreatitis, and one of the important reason of the Acinar cell injury is the increase the calcium because it can affect the mitochondria and it can cause mitochondria dysfunction. And also, since calcium hemostasis is sensitive to the cellular redox state, is very important. As I mentioned about this before, it is one of the important page. And as I start before, but we can see all together, but it's a little hard, but we can manage it. The first one, start ROS. As you see here, ROS, it can start unbalanced redox signal. The first one, oxidation or thiolation of the protein kinase and phosphatase happen. In this case, NF-kappa B activation can be happen. Also, disulfide stress can be start because it can affect in the disulfide bind, and it can inactivation protein phosphatase and MAPK activation can be happen. And the third mechanism, it can cause histone acetylation in the chromosome and activation of histone acetyltransferase complex, and again activation of the NF-kappa B and the STAT pathway. And the last one, the range calcium signaling, intracellular hypercalcemia, calcium amount in the cell increasing, and the premature activation of trypsinogen and the trypsinogen B activation. Okay, and also it can regulate transcription and act as a signal molecule and defect against the pathogen. Okay, now go from the other side. Okay, all of this pathway can affect tissue cell damage because of the effect in the cell, acinar cell. Okay, now we go out from other way. As you see here, ROS can indirect activation of the arachidonic acid cascade, and it can be COX and LOX, and it can be cause thromboxane activation, vasoconstriction, and the platelet aggregation, and can cause coagulation. Also, it can be LOX, it can cause affect the production of leukotriene B4, leukocyte activation and discharge of the lysosomal enzyme. It can also affect in the tissue and cell damage. Other mechanism, ROS can lipid peroxidation happen, increased permeability, because we know that in cell membrane we have a phospholipid, increased permeability and the deformability of the plasma membrane and the intracellular membrane. In this case, intracellular leakage of the proteins and influx of calcium happen. Also impaired enzyme function, because it can affect in the conformation and configuration of the enzyme. It can react with the DNA, and it can damage DNA response, and it can cause effect p53 activation and apoptosis happen. Or it can cause DNA damage, can cause the PARP activation, and necrosis can be happen. All of this mechanism can cause tissue and cellular damage, pancreatic necrosis, and multi-organ failure can be happen. Also, from the first three cascade, we can have the activation of the pro-inflammatory cytokines and amplification of inflammation, and systematic inflammatory response syndrome can be, and severe acute pancreatitis. Usually it can wear out treatment. The other mechanism of the molecular and cellular in the acute pancreatitis, autophagy. Autophagy is the lysosomal-mediated degradation pathway in the secretion and degradation of the protrypsinogen or protrypsin. And usually protrypsin granule in the pancreatic acinar cell, okay, in the vesicles. And because of endoplasmic reticulum stress and the mitochondrial dysfunction, which I mentioned, leading to necrosis of acinar cell and autophagy inhibitor, and the chloroquine could inhibit. You see, it is very important. Sometimes we can use chloroquine. This is product we can use for the treatment of the acute pancreatitis and any deformation, and also decrease the severity of the acute pancreatitis. As you see here, it's very important and very clear. Okay, as you see here in the inflammation, if you see the relation between inflammation and impaired pancreatic autophagy, for example, when we have a high amount of ROS and activation of the P62, it can cause endoplasmic reticulum stress and increase NF-kappa B and STAT3 activation. Then in the cytokine and chemokine activation can be happen. Okay, and usually they inhibit the release of interleukin-1 beta and interleukin-18. Okay. And the other cascade is very important between impaired pancreatic autophagy, accumulation of the and the dysfunction of the fragment of mitochondria, ATP, and usually mitochondrial dysfunction, ATP formation decrease, AT drops, and necrosis can be happen. Release of the damp can be start and activation and accumulation of the inflammation. Also, inflammation will be increased. The last relation between these two, it is a TBK activation happen. Again, it can cause NF-kappa B activation. IRF3 will be increased and activated. IFN signaling can be start formation, and the CCL5 and can be activated. In this case, also NF-kappa B can cause inflammation. Acute pancreatitis treatment, usually no effective therapeutic or treatment against this disease, and no effective therapeutic we can find for this disease. Usually prevent acute pancreatitis is important. Current drug therapy usually is the symptom for we use anti-pain, anti-inflammatory, inhibit the pancreatic enzyme secretion, and also with treatment of sharp pain and enteral nutrition for prevent bacterial translocation in the GI tract. Also, the lack of effective drug therapy, the blood pancreas barrier hinder the drug delivery toward the inflammatory pancreas, and single drugs cannot be sufficient to manage acute pancreatitis because of the complex of pathogens. Also because of the high amount of the activated enzyme in the pancreas, it can very hard to treatment because of this enzyme. Usually it is digest enzyme, and it can digest Acinar cell and ductal cell. Commonly used drugs in the clinic for acute pancreatitis within the 74 hours. Usually we can use, depend on the severity of the acute pancreatitis, we use fluid resuscitation and analgesia like atropine, enteral feeding, for example, with the tube, improvement of the interstitial mucosal barrier function, and reducing complication. And if you see here one of the table list of the drugs in the acute pancreatitis, for the analgesia we can use atropine, which really responsible and reduce the pancreatic secretion, for blocking the exhaustion of the zymogens granule. Also, we can use meperidine, and it is a systematic opioid narcotic analgesic for the relief of pain, meperidine. Also, we can use the pancreatic secretory trypsin inhibitor like pantoprazole, the proton pump inhibitors. Also, we can use alenistatin, and also we can use gabexate because it is acting this systematic low molecular weight protease inhibitor, or we can use somatostatin, which inhibits the secretion of the pancreas enzyme, protect the intracellular barrier, reduce intraperitoneal infection. And also we can use gram-negative bacterial antibiotic like ciprofloxacin, because it is good antibacterial for the prevent infection, and cefoperazone, it is also used, or aztreonam, we can use also aztreonam. And the last one, you can use anaerobic antibiotic like metronidazole for the anaerobic microbes in the GI. Drugs in the clinical trial for acute pancreatitis, one of the there are many drugs which comes to the clinical trial, but one of them is the Oxidative. It is used for the treatment of the pancreas, acute pancreatitis. It studied in the clinical trial starting to 1021 in the 216 patient, and it is usually it is in the clinical trial research. And conclusion and future direction, there are emerging a batch of the bioactive drugs and novel drugs delivery systems for the pancreatitis treatment. Many of them are only used in a simple animal model, which is insufficient for preclinical study because of the toxicity and drug adverse effects and side effects. The large sample multi-center study have not been carried out, and the Canadian large-scale trial and mechanistic study and the statistic support are also need to help and achieve more effective treatment in acute pancreatitis. I hope it will be good, and thank you for your paying attention, and I have a great I hope we can continue the other lectures about inflammation and also other GI tract diseases. Thank you very much. Have a good time.